Okay. Work me through this one
So
here.
this one, it was kind of funny because it's like, oh, which ones are most effective in achieving the goal? And they're just trying to, it's like I don't know, maybe like a public health question, not really sure. And I'm like, oh, this is something I haven't done in any of my practice materials at all.
Sure.
And I'm like, okay, they're trying to get the most, they're just trying to serve the highest number of people. Um, and they're like, no, it's increased investment in primary care services. I was like, oh, telemedicine, but they're like, oh, telemedicine is too specialized to like rural. So is the mobile clinic that's too specialized to just rural. And the response is like, that's really it. It's just something that's like just a fact sort of thing. It's not, I'm like, oh, telemedicine makes sense, but they're trying to cover all patients across all
Sure.
income levels and stuff. So
Exactly. So I
I
mean,
get
a good
that.
way to think about this is for one, you're on family med, right? So
Mhm.
anything that is dealing with increased primary care is probably going to be your answer. That's number one.
Okay.
Number two is if you think of telemed, right? The issue with telemed, it's a great idea. But when you start getting in lower social economic populations like Medicare, Medicaid, a lot of them don't have internet. A lot of them don't have laptops,
Yeah,
right?
I did like a contractor for a company that did that. They issued like phones for that in particular to that
Yeah.
demographic
So
group. Yeah.
definitely for sure, if getting more PCPs in the area is going to help a lot more. So
Okay.
because
Yeah, it was just
Medicare and
sort of a
Medicaid will
fact.
pay for that. So perfect.
This one, there's been a bunch of questions about this, I get one like every question set seems like nocturnal, uh,
In your
enuresis.
mm-hmm.
And it's like it was confusing with the steps. It's like the first thing is the like behavioral modifications. It seems that like behavioral modifications are first with the and then with the alarm.
Mm-hmm.
And then it seems that they go to desmopressin or like that ADH. But in this question, like, oh, reassurance only. And if you
Okay.
look at the explanations, it's like, okay, it's a secondary treatment. I know it's not first to do medication. Um, and I think it just needs like a longer um time. I think what was let me see here.
Yeah. Enuresis, monosymptomatic, non-symptomatic,
You
bedtime.
do a urinalysis to make sure it's not like diabetes insipidus or something
Yeah.
like that, which they
Early
said in the question. Yeah,
primary.
it's after 3 to 6 months of initial therapy, which is like the motivational therapy or the alarms. And
Yeah.
it just was confusing to me because I'm like, okay, past 2 years never had a dry night. They're concerned.
Yeah.
Um,
Hey,
and it was just kind of confusing that I'm like, oh, okay, it makes sense that you'd move to this, but it's not. It's reassurance.
yeah, it's kind of an interesting thing, right? So, primary management, treatment of coexisting conditions, patient and parent education, and motivational therapy, including reassurance, right? Um, so I would say, I mean, desmopressin is kind of, in my mind, for kiddos, is kind of the last line, if that makes sense, right?
Okay,
So,
makes sense.
in your mind, you have to be thinking, okay, so you want to educate first. After education and telling mom, like, try this, try this. If that doesn't work, then you do the enuresis clock.
Okay,
If that doesn't work, then you try the desmopressin, right?
okay,
Because that's like medication, right? So,
sure. But yeah, it just seemed like I was like I read it as 2 years, and I don't think that's really how I should have read it. Where it's
yeah. So the way you should be thinking is like kind of she's never had a dry night. She's 6 years old, but did she just turn six? Right.
okay,
Um, so you know and have they kept a diary? So
right,
I think a little bit more investigation here first,
gotcha.
before kind of putting a kiddo on desmopressin. That's all.
Okay, okay, makes sense. Let's see which of the following is most appropriate step in management. 44-year-old man, lump in his neck. Oh, this was the lipoma.
Okay.
Um, so lipomas, I learned from this question. I'm like, oh, it's just this growth. It's benign. It's not gonna it's just sort of could be a little bothersome or something. I mean, we used to have dogs that would get them, and I know there's nothing you do about it. You don't
Yeah.
biopsy it. I just was thinking, oh, you would biopsy, but that's more of like if it was in the breast tissue or something else.
Yeah, and it's been 5 years, right? So
Yeah, it's
um,
been a while.
it's been a long time. It's stayed the same size, right? It's
Okay.
mobile, right?
Even though
Not
it's
really anything
tender,
to-
it's kind of okay, or
yeah,
okay.
well, physical exam shows a 4 centimeter non-tender, moderately firm.
Okay.
So,
Okay.
that's the thing you're looking at. And of course, you know, um, a lipoma in the area that gets skin abrasion and stuff can get tender if you accidentally bump it and stuff like that. But for the most part, right, when you're palpating a lipoma, it's not going to hurt. So
Okay. This one was kind of simple in terms of it's just ultrasound before biopsy.
yeah.
Um, as a, like a general
Mm-hmm.
rule, 47-year-old woman. Seems like she has hyperthyroidism. I always get confused on and then her TSH was low at 0.1. So I always get confused about, okay, ultrasound, either radiotherapy or like FN or like fine needle biopsy. I just always get a
Sure.
little confused on that.
So
Um,
think of it like this, right? For thyroid, there's a very specific way you want to go about it. Um, if you want to evaluate the thyroid, let's say she has hypothyroid, hyperthyroid, whatever it is, right? You want
mhm.
to get a thyroid ultrasound to see. I mean, obviously your labs first, right? You always
Yep.
want to get labs first. So
Yep.
TSH, sometimes you'll get free T3, free T4 to give you a
Mhm.
little bit more information. After that, then you're going to get a thyroid ultrasound because you can't really do an FNA because for the most part, because you don't know what you're FNAing. You know what I mean? Like
Okay.
some of these nodules are really small, so you can't feel
Okay.
them. So you want to do an ultrasound first. If the ultrasound shows, oh, there's a nodule, right? Then from there, depending, right, this gets a little bit more detailed, depending on the characteristics on thyroid ultrasound. So for instance, if it has microcalcifications, if it's, taller rather than wide, right? Things like that, then you're worried about potential malignancy. So that's called a TRAD score. Okay, this gets into endocrine, but that TRAD score is just a score of how it looks on ultrasound, and based on the risk on that scale, the higher the score, then it'll push you to do a fine needle aspiration.
Okay.
Okay, fine needle biopsy will then give you a result telling you what is the likelihood that is malignant. Right. So,
You would aspirate first
say it again.
that
Fine needle biopsy is the same as cord,
the
or like,
same thing, right? Okay.
yeah, same thing,
And
same.
then
Yeah,
with like radioiodine uptake, sometimes they're like, oh, hot nodule. In
yeah.
my head,
So
like, okay, hot nodule is cancer. I always like confuse, or it's not cancer. Like
sure,
I was confused in that.
sure. So there's a test that is radioactive iodine that lights up. Okay,
Hmm.
that's different than iodine therapy. Iodine therapy is like using radioactive iodine to kill the thyroid. Okay,
Okay.
so that's not the same thing. You're talking about like an iodine scan, okay,
Yes.
where you're trying to figure out if it's
Uptake
a hot.
testing, right? Or
Say it
something like
again.
that. The uptake testing, I think.
Yep, iodine uptake test, right? Um, and the reason why is because iodine is needed, right, to make thyroid hormone, right? And
Okay.
so that test is kind of outdated. We don't really use cold and hot nodules anymore.
Okay.
Um, because hot nodule like okay, let me kind of work you through this because it's kind of confusing. So here's your thyroid, right?
Okay.
Let's say you have a nodule, okay, but before you have that nodule, right, before you have this imaging or know that nodule's there, you're gonna have your thyroid labs, correct?
Okay.
If your
Yes.
thyroid lab is normal, right, so normal TSH, right?
Hmm.
So your euthyroid, right? Meaning you have normal thyroid hormones, and then you get a thyroid ultrasound. Just because let's say maybe you palpated a nodule, maybe, okay, and then you see this nodule, okay. You're not gonna do an iodine uptake test because you're gonna fine needle aspirate that if it looks suspicious, regardless if it's hot or cold,
Okay.
okay. So you might be asking, okay, so when do we do the iodine uptake test? Okay, so you do the iodine uptake test if, okay, if your TSH is low, meaning your hyperthyroidism, right?
Mhm.
And T3, T4 is like elevated, right?
Okay.
So your hyperthyroidism. So what are your differentials? What can cause you hyperthyroidism?
Graves' disease.
Okay.
Um, I mean, you could be euthyroid too, so it could be like in one of those phases. I mean, it could be some of the ones that cause like hypo,
Okay.
um,
Like Hashimoto's, right? Initially, the initial
Hashimoto's
stage.
or ure the Quervians, like the
Yeah. So,
one that
so
hurts.
I think you're understanding that there's a lot of things that can cause hyper, right?
Sure.
Not just Graves. Okay.
Sure.
So then you get a thyroid ultrasound. Okay. And the thyroid ultrasound shows that you have, let's say, two nodules.
Okay.
Okay. And you also have a goiter. Okay. So, your thyroid is larger than it's normal. Okay. So now the question becomes, right? Is it because you have Graves that causes you hyperthyroidism? Is it because you have a adenoma, which is a nodule that secretes T3, T4, right? So
Okay.
you can't differentiate. You understand what I'm saying?
Yes.
Okay. So now what do you do? Okay. Now the radio iodine take makes sense because if the radio iodine take lights up just in this nodule, then you know it's a active adenoma
Okay.
is causing hyperthyroidism. If it's diffusely lit up, that means it's Graves. You get what I'm saying?
Gotcha. Yes,
So
that makes a lot of
that's
sense.
really the only time that you're using this thing.
Okay.
Um, but other than that, nowadays we bypass that the iodine uptake test and go straight to FNA for the most part.
Okay.
Okay.
So big picture, it's like labs, then ultrasound, then fine needle biopsy.
Mm-hmm.
Okay. This one, I think I like overthought it on this one, and I'm like, oh, it couldn't be, like especially this number 10. I'm like, oh, it couldn't be ischemic because they were like, oh no, I think the person didn't or did have, I can't remember the question, where the question is.
Those pulmonary edema,
If it's on.
bilateral X-rays, pulmonary lab show increased BPN. Echoes, gold standard shows reduced ejection fraction. Heart failure treatment involved management underlying conditions as well for therapy, preserve myocardial.
I can't remember
What?
why I
I'm
chose this.
confused. What is the question?
I don't know. I can't remember where the question is. I might have it in my thing.
Patient clinically presentation. Oh, that's kind of weird. It doesn't show the question, so I don't know
It
what's
should show. Hold on, let me see if I have it. I should have it.
the
Um,
patient's clinical presentation and echocardiogram showing an ejection fraction of 20% with global hypokinesis. Um, yeah, I don't have the case for some
hold
reason.
on, I might have it here. Is this 4 or 5? I don't know which one this
This is question 10, it seems like.
is. 10. Let's see. Question 10 is 13-year-old boy on this one. This must be this other one. Let's see. That's 4. So this is 5. Question 10. Oh, it's funny. I don't have it on mine either.
That's okay. That's fine. Um, I assume that, if I were to guess kind of what the clinical picture was, probably an older person
Yep.
that probably had like a myocardial infarction that had.
Correct. They previously had one. So I'm like, oh, it couldn't be that because that's
Yep. So if your heart kind of dies, right, it can balloon up and cause ischemic cardiomyopathy because
okay.
those muscles no longer live, so they can't pump, right? And so
Okay.
you're going to have a lower ejection fraction. And then what is this?
Okay.
Admitted
And then it's
ejection fraction.
if you get one, you can't, it's like one of those
Yeah.
two
So
part.
yeah. So here, right, you're trying to, in a sense, right, help the heart from getting too congested, right, because it can't
Okay.
pump well. And so aldosterone antagonists will help here.
Okay.
So it's gonna
Just
block.
offloading fluid, right? As
Yep.
opposed to
Hmm.
okay. Okay.
And help with remodeling of the heart. So
Okay. More than more than like the AT2 blocker there.
Yeah, because if it's an ACE inhibitor, then I would say that's kind of a tough one to choose against. But
Okay.
this is slightly better for
Okay.
I think mortality, morbidity.
Okay. This was a strange one to me. I never thought to answer this on this. That the like a small child's at risk for developing iron deficient anemia.
Oh yeah,
Um,
yeah,
I didn't really know that. So I wasn't thinking that at all. And I was thinking more of that it's like a thalassemia or a sickle cell issue.
sure.
And it's not. So it's like conjunctive pallor, hematocrit is down, mean corpuscular volume is down, blood pressure's down, even though the child's like, okay, 50 fit, like in the middle of the percentiles for height and weight. I'm like, okay, it could be something like that. But
Yeah,
they were saying, oh, it's iron deficient.
yep.
Um, Sometimes I don't pick these up from the labs like very quickly.
Yeah, so if you have mild conjunctival pallor, right, you're already thinking, oh, maybe some kind of anemia, right? So
Mhm.
they wouldn't mention pallor unless there's anemia. And
Okay.
then for hematocrit, right? Formula for hematocrit, yeah, is hematocrit divided by three. Yeah, hematocrit divided by three will give you a hemoglobin. So kids'
Okay.
hemoglobin is around like 9 point something, so that's pretty low.
Okay.
And then mean corpuscular volume, um, it's on the lower side, right? It's
Yep.
micro, right? Because 80 to
Definitely micro.
100 is normal, right? And so this is
Mhm.
microcytic. So then you if you're thinking, oh, that has to be some kind of anemia of like iron deficiency anemia, then the
Mhm.
first thing you're gonna ask is, are they getting enough nutrition as a kid?
Okay.
So
Okay. Um, this one they tend to ask about this a lot, the transient synovitis in the hip.
okay. Mm-hmm.
Um, my thinking was ibuprofen, even though I know kids can't really give them ibuprofen, right? You have to give them acetaminophen or
It's up to a certain age. I think
okay,
it's under, you can't give it under 3. Hold on, let me look it up. I can't, I think,
okay.
because their kidneys took a hit. Let me see. What age can you start giving ibuprofen? Over 6 months of age.
Oh, okay. You can. Okay.
Okay, so just so you know, so you, at 4-year-old you can give ibuprofen.
Okay.
So, I
But
just
what I
didn't give
missed
the
was
lower cutoff because we give ibuprofen to kids all the time, like 2 years
oh,
old,
okay.
we give it all the time. So I
Okay.
I just know the very lower end. Usually, when we do ear tubes for kids, we tend to stay away from ibuprofen because those kids can be pretty young, like 8 months, 9 months.
Okay.
So I think we wait usually about a year or older to start giving that. But
Okay.
yeah. So ibuprofen, this is kind of the transient synovitis, right? Just inflammation of the synovia, right? So
After a
best,
viral illness, usually. So that which
yep.
they said with cough, runny nose
Mm-hmm.
like a week and a half ago. So I
Yep.
sort of missed that part.
Yeah. So the best thing here, just transient inflammation. So just pain control temporarily, right? And it should go
Okay.
away.
Okay. Which they said they're like, yeah, treatment is supportive and you could use an NSAID like this, but it wouldn't
Exactly.
be the first step in management. It'd be just confirming that it is the
No, no,
trans.
the answer is ibuprofen.
Oh, the answer is ibuprofen. Oh, whoops. I mean, I mix it up then. Okay.
Yeah, yeah, yeah. You want to give ibuprofen. X-ray, right? This is, X-ray is not going to give you anything, right? Because there's
Right.
no fracture, there's no bony defect. So
Right.
diagnosis is clinical here and just transient.
Okay. I flipped it in my
Okay.
head.
Yeah.
This one I didn't, this one I learned, I'm like, okay, the rule I know for DEXA was 65, all women 65 plus, but then they're like, oh, or earlier if they have multiple risk factors.
Yeah.
So this patient's risk factor was fracture in her wrist, also smoking for 30 years, also a risk factor for this.
Sedentary
So that's why
lifestyle.
it was DEXA now as opposed to, oh, follow up in a year.
Yeah. So also sedimentary lifestyle is a risk factor too, right?
Okay. Okay.
Yeah, because remember, osteoporosis, to prevent osteoporosis or protect your bones is actually like body weight exercises, right?
Weight, yep,
Or
weight bearing or
weightlifting,
lifting.
right? Exactly. Right. And so, not walking, sitting, etc. Right. Her bones are going to degrade even faster. Right.
Okay.
And so, definitely for sure, she meets all the criteria here.
Okay. This one I didn't see as celiac when I was reading it at all.
Okay.
Um, and it seems to be it's come up a few other times. I picked it up in I think a UWorld question the other day after doing this, and I'm like, oh, okay, I see it now. So it's just this weight loss with anemia.
Okay.
And that's not like I don't think it's specifically an iron deficient anemia. It's just like an anemia because they're not able to absorb. Um, and then it's, there's villus atrophy, there's the IgA you could test for. I wasn't too sure on this one, but after reading the explanation, I'm like, okay, this makes sense. And I was able to pick it up. So it's like the crypt hyperplasia.
Yeah,
Um,
so the way I would put this together, so make sure that you have this clinical picture of celiac, right? It's
yes,
usually somebody that's younger, right? 31-year
yes,
old, so she's younger. It's a chronic issue, right? So
yes.
progressive fatigue and lack of energy. They'll have some weight loss because they can't absorb, right?
Hmm.
She has history of, 2-year chronic history of diarrhea. That's not normal.
Hmm.
Flatulence, right? Because the stools are going to be like really, gassy and fatty, right?
Hmm.
Um, then if you kind of take a look at it, right, no
I
other
think the
abnormal.
Peru thing like bothered me. I'm like, okay, why would they say travel to Peru? But it's sort of like a distractor
Yeah, I
in
mean,
this one.
yeah. So I would say, put it all together, right? Younger person, flatulence, diarrhea, 2 years, right? Some
Okay.
anemia, microcytic anemia, right? Um, a little bit of microcytic anemia, and then now it's like, okay, what's the most? That's why they always say, what's the most likely mechanism, right? And
Okay.
so, bacterial invasion of the bowel wall. I mean, no fever, right? No chills, and it's not going to last 2 years, right?
Okay.
Amyloid infiltration of the bowel, too young for that. Like amyloidosis, way too young for that.
Okay.
Enzyme deficiency, like lactose intolerant, they'll talk to you about like
Milk specifically, right? They'll
milk and
mention or
stuff.
cheese or
Exactly.
dairy. Okay.
Exactly. Intestinal hypermobility. I don't know what exactly what they're going for there. Vitamin deficiency. I mean, what vitamin are you talking about, right?
Well, I
Um,
would say no because it's not like beer 9 that they ask about a lot because it's
yeah,
acidic. So I'm like, okay, throw those off.
exactly.
Um,
Exactly. All right. Good.
okay, this one was like an ethics question. I really wasn't sure. And it's like, so the patient had a advanced directive to not resuscitate, but then upon admission said to please resuscitate him. And then wasn't sure. I'm like, oh, like I don't know which. And it seems like the rule is even if they have that, but they tell you when they're
Yeah.
conscious, and able, that
Yeah.
you adhere to their wishes in person. But I was wondering, what if it was the opposite way around? What if they had advanced directive that said to resuscitate, and then when they came in, they
It's the
said don't.
same.
Same? Okay. Doesn't
Yeah, yeah.
matter.
Like as long as you're coherent, right? The advanced directive is in case you deteriorate and and mentally incapable of making a decision
Okay.
that is in place. You understand what I'm saying? So and
Yes.
also like you're unable. So for instance, give you an example, right? You have an advanced directive that says do not resuscitate. You get into a really bad car accident and you're mentally not there. Your GCS is like 5 and you're on a ventilator, right? Or you're,
Mhm.
let's say you're about to be put on a ventilator. They read your advanced directive, says do not resuscitate, so then let you pass. You understand what I'm saying?
Okay. Okay.
Right? If you have advanced directive that says do not resuscitate, and then you get into a trauma and it's bad, but you're like, oh, I want to fight this, right? Like you're coherent. Like I broke like all the bones of my body. I want all the surgery. If you're telling them if I crash, I want you to do CPR and resuscitate me. That will supersede your advanced directive.
Okay.
Because imagine the reverse issue. I always think of it. How horrific would it be if you made an advanced directive that could not be changed?
Right. That's
Right?
true.
Yeah, you'd be like, no, 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 I want to be saved, but and then
And they would go with
doctor's like,
the thing.
yeah,
Okay.
you get what I'm trying to say, and then the
Yes,
doctor's like,
absolutely.
well, legally, what you did 5 years ago, right? And so, yeah, it's not binding as long as you're able to make a decision clearly.
Okay.
Okay.
Okay. Makes sense. This one I just missed in thinking that it could be parathyroid. I really just wasn't sure. 65-year-old woman. And they're asking, okay, which test is most appropriate to perform next? So 65-year-old woman, refill her prescriptions, like establish new patient. She's on a few different medications for hypothyroidism, bipolar, schizophrenia, no flat affect. Her HIV, hepatitis C are negative, and then in addition to measuring serum lithium concentration, which would be most appropriate, I went up here and I'm looking and I'm like, okay, I know her potassium is high. Calcium is also high. So I guess when I see calcium high, I should immediately think, PTH, that she could have like a PTH issue, like a hyperparathyroidism happening. I don't think phosphorus was low. Oh, no, they didn't do it. They didn't show it.
Yeah.
And her vitamin D was high too. So I'm like, okay. I remember looking at
Well,
that.
normal is greater than 20, so
Or
that's normal.
normal, excuse me, normal.
Yeah, so normal. So I mean, also looking at the creatinine is good too, because if you
Okay.
low creatinine, I mean, too high creatinine, that means you have kidney failure,
Okay.
right? But the creatinine's fine for her age. It's not elevated or anything. But the key thing here is this, right? High, right? Calcium. I mean, very high calcium levels,
Yep.
normal, right? Vitamin D, right? And so you're like, oh, okay, so something's out of whack here, right?
Okay.
And so the next thing that you want to test is seeing, okay, so what's the parathyroid doing? Because it's part of the chain, right? So
Hmm.
in theory, if correctly, if you have, this going on, then you potentially might have a parathyroid adenoma secreting a bunch of PTH. So
Okay. This one was just weight loss for blood pressure. So for hypertension, I'm thinking smoking. It seems this came up in a UWorld thing as well, where it's the best thing to reduce hypertension is weight loss.
yep.
I think they said like every kilogram or every pound is like -1 on their systolic blood pressure. So it's like that's the best way as opposed to smoking.
Yeah.
Usually the answers are smoking cessation, but this is one of those circumstances where it's
Yeah,
weight.
what you're 100% correct, right? I mean, all of these, in a sense will have some kind of effect, right? But smoking definitely has a risk factor for almost everything. But for
Mhm.
high blood pressure, definitely for sure, weight loss and low salt diet will help too. But
Okay.
yeah,
This one I wasn't sure on, and what I learned was that so even if someone has uh like chlamydia or gonorrhea a few months ago, I think you have to retest like every 6 months, through 3 to 6 months, it said that's what they want. Even if they're asymptomatic, just to confirm that your treatment was effective.
yeah, because some of these, I mean, um, some of these sexual transmitted diseases, right? They're like asymptomatic, right?
Mhm.
So, and sometimes it's like watery discharge, right? Which you may or may not realize. And so, definitely
Okay.
for sure, you want to test because it's not only good for the patient, right? But you don't want to, you want to prevent the spread, right? So,
Yes. I just didn't know that you retest again for the same thing after that. So it makes sense though. After I'm like, okay, it makes sense. Let's see. Of 65 men with coronary artery disease, 38 had abnormal stress test. They wanted sensitivity. So my understanding of sensitivity or specificity, sensitivity is of the folks who have the disease, how many of them then test positive? And then for specificity, it's of the folks who don't have it, how many test negative? And then I always mix up positive predictive value, negative predictive value. I don't know why. Um, but I seem to like flip those all the time.
yeah, sensitivity is how much can you catch?
Okay.
Screening test, when you talk about a screening test, every screening test wants to be highly sensitive. You want to, excuse me, you want to catch every possibility of it being positive.
Okay.
But a very sensitive test has a higher amount of false positive, but that's okay. You'd rather be wrongly positive than miss somebody, right? So
Right.
screening tests are always very sensitive. After someone tests positive for a screening test, then you want to do a test that's more specific for coronary disease. You get what I'm
Okay.
saying? Or specific to that cancer. Positive predictive value is just I have to kind of draw this out. It deals with the incidence. Okay. Does it tell you here?
Yeah, it says at the bottom, it's like or how it's I just always confuse it in my head. Hold on, let me
Okay, so let me. I think I can't remember his prevalence or incidence. I can't remember the right word, but so let's say okay, the way I do the example is this. Okay, so summer months, okay, versus winter.
okay.
Okay, and we're talking about the disease of the flu.
Okay.
Okay, and we're talking about each population has 100 people. Okay. And I'm going to make an exaggeration so it makes it easy. In the summer, 1 out of 100 people will get the flu. In the winter, 99 people out of 100 will get the flu. Okay. That's the absolute value. That's the, I guess, the prevalence at this time.
Okay.
Okay? All right. So now I have a question for you. Okay. If out of these 100 people, if I gave them a flu test, okay, a flu test, and it tests as positive, am I going to believe that test? Yes or no?
Not really, because most people have it.
Well, that's what I'm trying to say. You
Maybe
get,
I guess you would. Maybe you
yeah,
would.
exactly. You get what I'm trying to say. If you do a
Okay.
flu test and it comes back as positive, right, meaning that they have the flu, you're going to trust that test in the winter, correct?
That's
But
it's like
if I do a,
a true positive. Okay.
yep, that's a true positive, right? And so that's positive predictive value, right? So the more people that have the disease during whatever circumstance, that test is more reliable. That's what positive predictive value is.
Okay.
Okay. Let's say I do a flu test in the summer that tests positive. Am I going to trust that test?
I don't think so because the prevalence is so low.
Exactly. Right. So that's why it's inversely related, right? It deals with prevalence, right? So I would be like, if they tested positive, I'd be like either retest them to make sure,
Okay.
or right, or don't even do the test at all because it's probably not reliable. Um, but giving you an example of the flip side, if I do a flu test in the summer and it comes back negative, am I going to trust that?
Yes.
Yeah, so that's negative predictive value. So the lower the prevalence and it comes back negative, you're going to trust that.
Okay.
Yeah, does that make sense?
Yeah, that makes a lot of sense.
Okay, perfect. Oh, I didn't mean to do that. Give me a second. Press the wrong button. All right, let's go to. Question.
Okay. So this one, the probenecid and allopurinol, they are for gout. They're more for preventative.
Yep,
And
yep,
this was asking, okay, he's already on colchicine, which is also like to prevent acute attacks. What do you give during an acute attack? It's an NSAID during the acute attack, which would be the indomethacin. So
yeah.
I
That's
was thinking just I was between allopurinol and probenecid. I'm like, I know they're both gout, but they're more of the, the beforehand
Yep,
preventative.
prophylactic, right? So
Yep.
these are to prevent the gout episode. Once you get a gout episode, these things are it's too down the line, right?
Yep.
So you want to treat them acutely, right? So NSAIDs, right?
Mhm.
Which helps inflammation, and then of course, right later on, you're going to tack these on too because you want to
Okay.
prevent future attacks. But in the immediate, right? That's why they stressed acute episode, right? That's the
Yes.
key here. So
Mhm.
indomethacin. But remember, I want just so you remember, colchicine is also an acute treatment too.
Okay.
Okay, just so you
Okay.
know. And the trick between picking colchicine or an NSAID is you have to look like, did they have issues with diarrhea? Because
Well, because he did.
colchicine,
So that's what I was thinking that's why I was thinking when I read it. I'm like, oh, I crossed out the NSAID right away. And I'm like, oh
yeah,
no, he has
no,
diarrhea.
but colchicine works differently, right? Colchicine is a
Yeah, I forget
different
the
mechanism
mechanism.
of action. Colchicine isn't a NSAID. It's I can't remember. It deals with some kind of like,
I think
man,
it's neutrophils. I think it has to do with neutrophils. Like,
yeah, so some kind of like stabilization or something. I can't remember exactly, but one of its side effects is bad diarrhea. So if you have
okay,
GI issues and stuff, you can't give people colchicine. So
okay. This one was because she's under 21 that there is no PAP. if they had just STI testing, that would have been fair, but they don't. So it's just no screening.
Yep. Good. Good.
Yep.
Good. Yeah, you have to wait until 21.
Mhm.
So,
Like a strict
and,
just 21.
yep. And then pap smear screening every 5 with co-testing or every 3 alone. So if you do the so if you co-test with HPV, you only have to do it once every 5 years, right?
Mhm. And that's for over 30 because you don't even do HPV under 30. So 21 to 30, just PAP, which is kind of, it's just a
Is that
rule.
right?
Yeah, it came up in another question too.
Oh, okay, yeah, yeah. Recommend cervical pap smear every 3 years between this and then and pap smear 5 with co-testing or this. Oh, that's
Yeah.
30 to
Because
65. I got you.
they're like HPV won't develop before, so you'll get it's just problematic. So they're like, okay, you know, HPV the co-testing is after 30.
After. Okay, cool. And remember, right? This is when you look at this screening, I just want you to know that this deals with people that come back negative testing, right? You understand that, right?
Okay.
Because if it comes back any kind of weird atypia, then it changes what you need to do, right? Then you
Okay.
probably like need to do some kind of
Probably follow-up work
follow
or
up. Yeah, follow
small.
up closely, right? It's not, maybe every year now because it came back abnormal, right? But I don't know if they'll test you. That's more of an OB question, but just so you know that this is like, oh, you test negative, so I need to see you 3 years. You get what I'm saying?
Okay. Yeah,
But
because
if
they
you
have
ever,
that in a colonoscopy question too, where it's like, yeah, the patient was 50 or something. They had like one or two polyps. And then like, oh, when do you do next colonoscopy? And it's like, oh, you could wait 10 years because there was no they
yeah,
weren't the polyps weren't cancerous, so they weren't so they said, oh, you can wait till 10 years. So I'm like, okay, you don't have to do
oh,
another
okay,
one.
cool,
It was kind of it's just these screening rules and stuff
yep.
that's on
Yeah,
this.
it's like these like minutia screening rules. I mean, this is
Mhm.
family med, so they're gonna ask you, all the
Yep.
screening stuff. So
This one I thought like I was on the right page with this one, but it was like the wrong mechanism.
okay,
Um, so it's like, okay, most likely caused this patient condition, 5-year-old boy. He has this pain after he eats, and he has low hemoglobin. The spleen tip is palpable. Um, has a bunch of gallstones. And I'm like, okay, something's going on here. I thought it was the like autoimmune hemolytic anemia.
well, you gotta blood smear, right?
Yeah,
Just
it's the spherocytes. So I'm like, okay, I know that the spherocytes is like usually in like pregnant women, right? When you put a line in and blood sort of comes out, you get the spherocytes usually. Am I thinking
no,
of that correctly?
spherocytes is when the red blood cells are completely circular, which is it's a genetic issue, right?
Okay. It's not
So
the shearing. What am I thinking? I'm thinking of the shearing issue. I'm getting this confused.
shearing is called those are called schistocytes.
Just this, that's what I was thinking of,
Yeah,
schistocytes.
schistocytes is shearing, right? That a lot of things can cause schistocytes, but spherocytosis or or hereditary spherocytosis, if you look under a blood smear,
Mhm.
they look like completely round and they're uniform in color. And the reason why that
There's no pallor, there's no biconcave. Okay.
nope, there's no pallor because think about why you see pallor on a red blood smear, like two circles and it's white in the middle.
Mhm.
It's because that I think of a blood smear is a 2D image of a 3D object. So your red blood cell is it's a concavity. So if you
Mhm.
split this like this, right, and you look at it, right, this is the white spot that you're looking at. So
Okay.
spherocytosis is a complete sphere. So any way you cut it, it's going to look the same. That's why there's no pallor.
Okay.
Yeah, it's like you're chopping a 3D object into a 2D object, and so
Okay.
if it's sphere, then you're going to see a symmetric circle, right, with no pallor. So, but yeah, if you have spherocytosis, you're going to have a lot of hemolytic anemia, right? Your liver or your spleen is going to try to chomp up all your spherocytes because it thinks it's like abnormal, right? It keeps
Okay.
marking it, and so what happens is obviously you get anemia, right? Which is
Mhm.
because your red blood cells are dying, but also on top of that, right? Every time that it chomps it up, it releases bilirubin, and the bilirubin will cause increased risk of gallstones, right? Which makes sense.
Okay.
And
Okay.
then the overreaction of your spleen and your liver of eating these things up will cause hepatosplenomegaly and things like that.
Okay. Okay.
And obviously the jaundice is caused by the bilirubin that's released. So,
Okay. This one I learned from this that during pregnancy, you're going to give the Rogram, like the Rho-D, you're going
mhm.
to give Tdap, and you can also give inactivated influenza. Those are the ones during pregnancy that you give, usually like third trimester. However, with this question, it was the only applicable one was the Tdap, which I didn't really know that. So I was thinking, oh, what could you give during pregnancy? And it's really you don't give any live vaccine, which is like the MMR or varicella.
Yep, those
And
are no go for
Yeah,
sure.
HPV you're not going to give because that's for like teenagers up to like I think 25 or 26 that they recommend for boys and girls for that. And then yeah, so I just took a guess with hepatitis B, and it's the Tdap. Um, and
Yeah,
they said even in this, like, say you have two pregnancies in 1 year, you're going to get two Tdaps that year, which I found I didn't know that either.
yeah, yeah. So I mean, yeah, Tdap's good. It's it covers a lot of things, right?
Mhm.
Also it's dead, right? Dead vaccine,
Mhm.
right? It's not live. So definitely for sure. Then the flu, like the dead flu vaccine is super good too, right?
Yes,
Yeah, they're gonna ask you kind of these, the
vaccine questions
vaccine questions.
and the
They're
schedule. Yeah.
Yep,
This
yep.
one I just thought was weird because it was a pregnancy one. I mean, in other questions they've done like HIV and stuff like that. That makes sense, but it's good to know that it's that one inactivated flu and then the RhoGAM, like the Rho-D, is
Hmm, hmm.
always given too. Not that that's a vaccine, but it's just something else that's I should know.
For sure.
Um, okay. So this one was funny because it's like a rule with the asthma.
Yep.
So what I learned from this is like, okay, if you have someone with asthma, which they're probably going to ask about because it comes up a lot, it's the short acting first, so short acting beta agonist like the albuterol first, then the inhaled corticosteroids, then the inhaled corticosteroids like up the dose, then it's going to be I think then only after that is it like the leukotriene inhibitor stuff. So it's like a bunch of stages or the long acting. It's like a few stages to get there.
Yeah.
Uh,
So the rule of twos is very important. You have to
okay.
know the rule of twos. Intermittent asthma is what it's called, right? So you got your mild asthma and then intermittent asthma, which is characterized by symptoms of less than 2 days per week, less than two times per month as needed. And so the intermittent asthma can be treated with right with just like albuterol, right, which
Okay.
is beta agonist, right?
Mhm.
And then if you have mild persistent, right, which is more than that, it's the rule of twos, right? Once you break over that two, right, so you have attacks two more per week, or
Okay.
you're waking up two nights or more per month, then you switch them over to inhaled steroids.
Okay. So in
So
this question, daily leads
daily
2 weeks. So
2 weeks.
that would be like 14 episodes. That's elevating this patient to
The mild,
mild
mild
persistent.
persistent, yep, yep.
Okay. So then that's when you would give the inhaled
Mhm.
corticosteroids.
Mhm.
Okay.
And also on top of that, right? Um they sometimes make it really tricky. Like, oh, during the day, patient only had to use the, albuterol one time this whole month, but she wakes up, three times a week coughing. So she also meets mild persistent asthma. You get what I'm saying?
Okay. Okay.
So yeah, they might trick you like that and say, they have one but not the other, right? So it might not be as obvious as, straight 2 weeks is okay, that's pretty bad, right?
Okay.
So just kind of be aware of the rule of twos, okay?
Okay. This one I thought was interesting. 'Cause I was not thinking that this was like a urticaria.
Okay.
Because in the question they're like, okay, diffuse itchy rash resolves, uses the diphenhydramine, like the Benadryl, to provide moderate relief, and it goes away, but then it comes back. So I'm like, oh, that's definitely not. I felt like urticaria was like one episode. So I'm like, okay, I wasn't sure. So I'm like, oh, maybe it's some sort of allergy because it didn't fit any of the other, I didn't like any of the answers, but it's really just no other indications. It's like it just happens that they're like breaking out. And the antihistamines, I guess, are working, but it's not bad enough to where you need like a EpiPen or something like that.
Yeah, yeah. So urticaria, I mean, it just means hives, right?
Yep.
And practically, I mean, this skin, I mean, skin is a weird organ, right? It can
Yes.
be caused by anything, right? You're
Hmm.
talking about your shirt. What I mean, giving you an example of my skin, right? We just moved here, and we had a lot of clothes from our boxes, and
Hmm.
whatever clothes were on the edges of the box that touched it, I got like, a little bit of a rash from it because I guess
Hmm.
my skin is super sensitive to the box, right? So you don't need like a radio absorbent testing, right? Which is an allergy testing
That's what
practically.
I was thinking. I was like, oh, allergy testing, but it's
Yeah.
not that
Yeah,
serious.
because you remember, okay, so once again, this I understand your answer. It's not a bad answer, right? Those tests are extraordinarily expensive, right?
Okay.
So
Okay.
you got to think to yourself, is like, okay, so probably something in the environment, maybe, even some people are like allergic to like their sweat if their sweat is on them for a long time,
Hmm.
right? So, you kind of do it based on history and be like, hey, you want to avoid this, right? If you're in this environment, right? And sometimes it's just, oh, your skin is super dry and irritated, put lotion on it, right? Change
Okay.
shirts, don't use that, same sometimes it's just like your detergent that you use for to clean your clothes. So you want to
Sure.
change that. But yeah, if it's kind of like a regular, like, it goes away with Benadryl, you don't have to rush to super expensive testing. So
Okay.
that's what I
Okay.
would say. So history is gonna tell you kind of how to manage, and then of course, if you've done everything and this guy just keeps breaking out, now you have to be like, okay, now we probably have to do some weird testing, right?
Gotcha. Okay.